distalization or full arch distalization. And again, there is Professor Dilmes. Benedict will show you amazing cases. He has his own system, which is amazing to distalize molars, to mesialize molars. You can do anything you want. Open bite treatment, canine management, and so on. I'm doing simple things in my office. So I look at this article and I said, yeah, why not? I could use, the retromolar area, which is a very simple area for myself. I agree with Professor Nanda. We have to extract the wisdom teeth, yeah? Otherwise, we cannot pull against the retromolar area. So, very class 2 patient, deep bite, massive deep bite. Yeah, this is class 2. Deep bite division 2. It's not an easy case, you see? So the moment we align a level, the overjet will increase. It's going to be a massive overjet, 8-9 millimeters, and then how do we reduce this overjet? So we will need some kind of tats somewhere, to retract the whole arch. Massive class 2, yeah? Full unit class 2 deep bite. I think it was overall quite a good case, apart from the aesthetics of his teeth. Right, so we started with always with the low arch level, aligner level, level the curve of speed because it's a very deep overbite. We bond the top, you see, of course, with bite blocks, otherwise there's no way you can cement the upper braces. And now you see, the bite is opening. We do have bite blocks though. But look at the overjet, massive. What do you do here? If the patient does not comply, he needs maxillofacial surgery. Simple as that. How do we do this? I'm not extracting. This is not the case for upper premolar extractions. It's not a good case for that. Yeah. So very simple mechanics. If you can try to, yes, extract the wisdom teeth, place 2 mini implants in that area, 10 millimeters, now we can have 12 millimeters, yeah, even 12 millimeters. Very simple mechanics, pull with power chains. So it's a total retraction of the upper arch, and you decide how long the power chain will be, together with class 2 elastics. So the patient is wearing class 2 elastics from the upper canines to the lower second molars. Yeah, you need good cooperation with them, of course, good cooperation. And you can see already this side looks much better. Final result, I was really impressed by the cooperation because this is good, yeah. Teeth are not beautiful, but it's a good result, I think, yeah, and within a couple of years of treatment. So upper retromolar mini implants, class 2 elastics. If you compare, you see the smile is still, it's not the best smile. The profile is still convex because no maxillofacial surgery was done. But otherwise, this is quite a good change. Look vertically, massive change. Overjet, massive change. Pretty good sagittal correction as well. Yeah, that's a big movement, I believe, before and after. Okay, and yes, maybe I want to show you another one, which is a bit more dramatic. Yeah, this one. This is funny because it's only aesthetic treatment. It's another huge overjet. So she said, I don't care about the perfection of the bite. I just want to reduce this without extractions. Without extractions. Yeah. How do I do it? Again, I have to extract the wisdom teeth. Yeah, you have to extract somewhere. Look at that. And then use the same mechanics. You see how proclined there? This is an extraction case. Or even you could consider some maxillofacial surgery here. So I use the same mechanics. And you see the retromolar implants, power chain. So you do the whole total arch retraction plus class 2 elastics. Once again, And before and after, I mean, the smile is a bit gummier because, of course, they get a bit of extrusion while tipping, but this is quite an impressive change, yeah? Before and after. Look at the body. It's not perfect, eh? It's not perfect. She's still a little bit class 2, but even this change in the overjet, it's quite good, yeah? So nearly corrected. This is another good one. A patient who was treated many years before when she was a child, and again she had this relapse, so proclination of the upper incisors. It's a class 2 long face, as you see, huge overjet gummy smile, yeah, and you see open-bite with an old bonded retainer. So of course you can think, shall we extract? Maybe. In this case you could extract 2 upper premolars to reduce the overjet, but we need to take records. Yeah? So you take a radiograph and you say, Jesus, you know, I mean, you see, this is the old retainer. So I took a radiograph and yes, apart, even here, you know, from this view already you see, so there is nothing up there. And then I looked at the OPG. Of course, I did also CPCT, but already from the OPG, it's enough to see that there is nothing, I mean, very little roots up here. Yeah, so what do we do? Probably 5-10 years ago, I wouldn't have started this. I remember when I talked to my British colleagues, they said, you're mental, you know, why do you start this case? Why? But just to show you what you could do. Of course you cannot use aligners because they will have anyway some force on the uppers or upper anteriors. So this is what you can do. Even buccally you could do the same. So just bond up to the canines. Yeah, leave the previous retainer, keep the canines there, so she can even then start with the class 2 elastic. Don't touch the upper incisors. So I did most of the treatment like that. You see she was wearing class 2 elastics here from the canines. And then, you see already the bite has improved quite a lot. And then in the last 3 months of treatment, I bonded up the brackets on the incisors, just to do this. A few degrees, 5, 6 degrees maybe, not more, yeah? So same mechanics, these are the 10 millimeter orthoeasy, yeah, with the total arch retraction. And you see now, finally, I have bonded in the last few months the 4 incisors just to do the final T. Of course, you have to monitor everything with the radiograph. So I remember every time I was taking the OPG, I was praying. God, I hope she still has got roots. I hope she has still got some roots up there, and they're still alright. Much better now. So then after 3 months of bonding up the upper incisors, I had to stop. I didn't want to carry on, yeah? And it's still acceptable. It's not perfect, but it's still fine. Yeah, so she was finished like that. A little bit of gummy smile though, but much, much better, you see? The proclination has reduced. Bite is reasonable. It's still a bit class 2, as you see on this side, but reasonable. Otherwise, you see, fair enough. I mean, you don't want really to overload these upper incisors. Final radiograph, you see, of course, the resorption is still there, but stable, yeah? Stable. You see, this is the last OPG end of the retreatment, and you can see the resorption, but it's pretty much as at the start. Before and after, you see the changes before and after. Yeah. And the 3 radiographs, I think those are interesting. Yeah, so the before and after treatment was about 12 months, very short. The start, and then during treatment, when I bonded, after I bonded the incisors, and then this is at the end. You see, not big changes likely. Right, I have just last couple of minutes, so just quickly I show you the last case, which is a multidisciplinary treatment, class 2, very deep bite, and again, oral hygiene is not the best, the tooth here is really dark, this also has got root canal treatment, so he will need some veneers or crown at the top. It's a large overjet with gaps at the top, as you see. I'm showing you this case mainly for this side because you see this is actually the class 2 side. It's a full unit class 2. So to show you how I did the distalization unilateral with the TADS and in office distalizer. Yeah? Initial X-ray. So I started again with the 2D. After the initial alignment, you see the patient is already wearing class 2 elastics. I sent the patient to the prosthodontist, to have some improvement of the upper anteriors. Even provisionals are fine. So we take all the possible records for that. And this is my friend Paolo doing provisionals. So it's composite. It's nothing more than composite after digital smile design. This is the planning. And then this is the composite after all. They look pretty good, although it's just the cheap composite. And I'm still working, you see, with the class 2 elastics. The patient has got buttons and is still wearing class 2 elastics. Then it's time for a distalizer. And honestly, if I have to use something simple, cheap in the clinic, I will have a labial button, sectional stainless steel 1925 with a push coil and the same palatal. You see, this is done by everything by myself. I just bend the things in the chair. So one ortho easy palatally, one buccally, and of course, you have to extract this. This was extracted later on. It's working well. Even this thing is working well. I noticed some crossbite tendency, so I corrected the crossbite with the asymmetric TMA expansion loop as we saw it before. So see, it's correcting bit by bit. It's correcting. We just need a little bit of seating. Now this is after the expansion. And here we go. So the patient then was ready for depot, of course still with the old provisionals. It's a fair result, pretty good bite, class 1 with a little bit gap there. So we will need now the finals to finish off pretty well, but still you can see even aesthetically he looks much better after treatment. Overjet and deep bite have reduced a lot, a lot. You can see that. Of course, it's time now for the finals at the top. So then Paolo, my friend Paolo, did the finals, and then I stopped. So basically 3 veneers, 1, 2, 3, and 2 crowns for central and lateral. And at that time we were taking impressions. Now it's all scans, so just using the scanner. And these are the 3 veneers and the 2 crowns. The cementation and then the final outcome. Right, so to finish this presentation, I would say that even in lingual cases, you can combine TADS with some segmented approach. Cantilevers, for example, power arms, uprighting springs, torquing springs. So segmented, I think, is still a great help, even for lingual patients. And we saw, you see, the treatment of impacted canines. Power arms with TADS are very good for incisors, so for retraction, intrusion of the upper incisors, especially in adults, periodontally involved patients. And then for class 2 malocclusions, bilateral, mono, unilateral, you can use some distalizers Or you can do it yourself, maybe with the retromolar implant, or maybe with the palatal implant, a sectional wire, and a bush coil. Yeah? But please, as Professor Nanda said, choose the biomechanics according to each individual patient. Thank you so much for your kind attention to enjoy the conference.
Thank you very much for your interesting presentation. Now, on behalf of